So what we're going to talk about now is these other classifications, we call them, but basically it's a series of things within the II product that you should be aware of in order to use the product effectively. So one of the first things here, Sarah's talked a little bit about member ID and gender. Date of birth has been de-identified, but it's age only in this case. The dynamic information is subscriber status. This is de-identified in WEO, product, PCP, and effective dates. So in your application, that's what we're using. Your member demographics in this case, you saw the age ranges in a couple spots already in the quick list. You saw that there's 0 to 17, 18 to 64, and 65 plus. What you didn't see was that we have a further breakdown. It's called age category 2, which you could have added as a column. That age category 2 has ranges, as shown there in age category 2, and it gives you a little bit of fine tuning. Now, one thing to keep in mind is you can see that for the 65 plus, we do 65 to 74 and 75 plus. If that's not enough in terms of the Medicare population when you pull it in, you guys, let WEO know, because that's one of those things that we can fix. We have many clients that take that in 5-year increments, all the way up to 100. So, something to think about. Member enrollment, when does that occur? In your case, 15th of the month. So if a member is a member on the 15th of a month, they're a member for the month, kind of thing. And that's pretty common in the industry today. We have first day, last day, any day, or day specific. And we have just a few clients that are using day specific. Most clients are using the 15th of a month. The next thing to consider is that members can be enrolled in multiple products over a time frame. And that's what the member enroll table does for us. So for example, you could move from Blue Cross Blue Shield to WPS to WEA over the entire 2-year time frame that we have in the application, and that'll be tracked as you go along. So we have Census Region, and we've already talked a little bit about how that's done in your area. Census Region up here, in this particular case here, we definitely have that. We've got state, we've got county. Your zip code is limited to 3. And there's your de-identified. Sarah's shown you that already. Catastrophic status. This is a part of the tool that allows you to actually fine-tune things. In this case here, if you want to find all of your members with a really high cost, $200,000 or greater, we've got a flag in there that says catastrophic status. And you can actually check that off and find them. You don't have to put $200,000 in the member list. You can actually just check it off. And we've got one for 100 to 199, 50 to 99, 25 to 49, and 0 to 20. Now, why do we classify them like this? One of the things we do when we look at PCPs and we look at population and we look at PMPM, if you're a PCP and you've got a couple of members that have had catastrophic conditions of $200,000 or greater, how are you going to look compared to PCPs that don't have any of those? Not very good, right? So what we want to do is we want to have the ability to pull those out of those calculations and only use the ones that make sense. So typically 0 to 25,000 are contained. Everything else is not contained. Did you use the same thing, Sarah? Is it 25,000 is the cut?
I think it was, and I think with the next release it's going to be 50.
Yeah, there you go. Yeah, many clients are moving to 50 now, right? So yeah, your cut is 25 for usage in PNA. It will be 50 and 2.1. We have all those flags set up in there. And then down here, it allows for exclusion of the outliers. Well, we consider those outliers. But if you're an actuary or underwriting or you're doing some financial work, you might want to exclude them on a different level. So that's why we give you the various levels that are built in there. And then you can also use it for threshold levels. So if you want to find out all your members that are $200,000 or greater, what their comorbid conditions are, you can actually just check off only members $200,000 or greater, get a list of all of those comorbid conditions. Now you can't get a list of the members because of course your members are de-identified, but you can see what the comorbid conditions are. And then you can actually look at within any one of those thresholds what's the driver of that particular one. So for example, let's take one of the lower ones, 25 to 49. It may be that a driver in there is asthma, or maybe it's, in your case, we just saw a really high number for the antipsychotics. Could be that's in there too. So that's something to look at. So health risk. We've talked a little bit about health risk. We haven't really dove into it deep. We're about to look at it a little bit more deeply. Health risk is illness burden. How sick are you? In this case here, within the application, we give you the ability to look at retrospective risk, which is looking back 12 months, prospective risk, which is looking forward 12 months, and strict age sex risk. So we give you those three things in there. Risk really is the expected relative cost or use. So how much are you expected to cost? How much have you cost? It's case mix adjusted. It's relative to 1.0. If you took your entire population and you got the average risk in there, would you have a 1.0 in there? Why? Sarah knows the answer. Go ahead.
Because the 1.0 is the national
Yep.
average according to your research database.
Yep, absolutely. So your number varies from that. And if you start to slice the population, Medicaid, Medicare, and commercial, your numbers are going to start varying widely from that. So if you wanted to set your numbers at 1.0, you have the ability in the application, and we'll see this in the cubes, to create your own formula. And you can divide everything. I think yours is 1.41, if I'm not mistaken, from a couple days ago. Yeah. If you want to divide everything by 1.41 and make yours equal to 1, you could do that. Most clients just leave it the way it is and say, okay, yeah, mine's 1.41. It's higher than the national. We use categories as they're used within the Symmetry product of ERGs. We stratify the risk into 26 different categories, which we'll see in a second, and they're assigned for each 12-month period. So for example, you've got period 1, which is the first 12 months of your data, period 2, which is the second 12 months, and 3 months worth of runout. We have risk assigned for each period. So you'll have a retrospective risk for period 1 and a retrospective risk for period 2 and prospective risks. Many clients will trend those over time by using a spreadsheet.
I have a question.
Yep.
How often is this risk methodology updated?
About every 2 years.
So is this the same methodology as
Symmetry.
Pro?
No. Impact Pro uses utilization in combination with this type of risk. This only uses claims and does not consider utilization. That is why Impact Pro is much more accurate in terms of an R-squared value.
But so if it's the methodology is updated every 2 years, you have to figure out some adjustment to do, otherwise your trending won't be accurate.
No.
Or does it change?
That doesn't change. It doesn't change that radically. Our next change coming up is going to be ICD-10, and we don't know what's going to happen there just yet because there's no ICD-10s out there to kind of actually compare to. We did do a major change back between Symmetry version 5 and 6, or maybe it was 4 and 5, I forget, where there was a huge discontinuity in the whole thing. And then we alerted all the clients, we told them what the discontinuity was, we told them to expect it, and it kind of went out. But it was much more accurate after that. Since then, the every 2 year thing, it's minor perturbations. Nothing huge.
Another question, and this is not related to this, but it's
That's okay.
on the member side of it. If a member has Medicaid, but then a member also has other insurance, where is the member assigned to Medicaid, or is the member showing up right? I don't.
So Sarah, the question is, if the member has Medicaid and another insurance, where is the member identified as? I don't know that.
If Medicare or Medicaid?
Medicaid.
If Medicaid is primary, it would be.
Medicaid is always the payer of last resort.
Seconded.
Well, I don't know if I can answer that confidently.
I can't.
I suspect it would be, it would be however the claim was paid.
Yeah.
That would be how the claim would come through. So if a commercial carrier covered the claim, it would come through as a commercial claim for a commercial number. If Medicaid picked up some of those members' claims, those claims would probably be tagged as Medicaid claims. Remind me how the member product or
Member enroll table?
yeah, well, member attributes are assigned based on the last day of the reporting period.
That's correct.
So depending on where you are in the application would determine whether
Yeah.
it's Medicaid or a commercial
Yeah.
attribute.
So a member from period 1 to period 2 could actually change from commercial to Medicaid, but within the period, they're not going to change. They're going to be whatever they are within that period.
As of the last time.
Yes.
But you can always get down to the claim level.
Right.
Where you will see changes over time if they're in commercial 1 month, Medicaid the next month, commercial.
In that
See,
case,
these situations would be ones where
rule, then we may have claims where the third-party insurance pays one portion of the bill, and we pay, as Medicaid, pays the other portion of the same code. So, not like a code level. So we may actually both be paying on the same thing.
So we would see a claim from Medicaid, paying $37, say, and a claim from the commercial insurer for the exact same date of service, the exact same code, and the commercial paid $25. Together, the provider is made whole at $52 or whatever it is, right?
So I think because of provider, or of member matching, we do have carriers submitting COB claims. So I'm not exactly sure if Medicaid would be considered secondary, or I'm not sure. To be honest with you, I don't know.
So I guess one of the questions I'll ask first is, how many are those? Is this like the majority? Is this like really tiny?
No.
Oh, okay. So when we're looking at,
Mostly on human services.
yeah, okay. So Sarah, what I would say to this is since it's that small of a volume, when we start comparing doctors, even in the Medicaid space, it's not going to make a difference in how those doctors compare.
Sure.
It's going to make some difference in the cost and use because it's going to get bucketed differently. But in the overall picture of why you're using the application, that shouldn't change reasoning for doing one thing versus another, starting a program, not starting a program.
Especially
The
if you're
mem-
the provider's side.
Yes, exactly. Now, so the member is going to be a member of one of them. I can't tell you which one off the top because I'm not confident, at the end of each period. And if we wanted to look into that, we certainly could get a few of those members, real IDs, get them to Optum, and we'd figure out where they ended up and why they ended up there. And then if you guys disagree with that or you want to change it, we'd have to change our logic to say, okay, make it here instead of there.
Right, and the duplicate checking that occurs on the intake
Mhm.
might actually flag that as a duplicate claim.
Right.
So is there any COB field that is submitted from us to you?
Yes.
Yep.
Okay,
Yes.
And then so you use that as well as the duplicates to identify
Mhm.
those members. Then there's some sort of algorithm to decide which insurer that member will be allocated to for the month. And so there's no need for any kind of COB field within two. Is that am I
Correct.
understanding that
Yep.
correctly?
Correct.
And the COB field, or any field other than the allowed field, which is the standard price, right? Standard price is used for everything. So even if that claim got flagged as a duplicate and we used one of the two claims, it's still going to be standard priced for you. So that's not going to affect anything.
Could you throw some light on what you said earlier?
Mhm.
The impact co uses utilization and claims,
Sure.
and impact analysis uses only claims? Did I
Yep,
get that right?
you got that right. Yep.
So could you explain that?
I think I have a slide on that, but let me explain. No, I'm going to quickly explain, then we're going to look at the slide. The difference here is when we assess patient overall illness burden or risk, right? Not episodic severity level risk, but patient illness burden risk. The way the applications work, both of them right now, you take all the claims that are coming in, the claims go through the ETG grouper, groups them up, right? And then what happens is, in this particular application, it goes into the ERG grouper, and such things as age, sex may get added to that at that point, and you come up with a number, right? And that number is your illness burden. In Impact Pro, something slightly different happens. It still gets grouped to the ETGs, it still goes to the ERGs, but now not only does age, sex come in, but utilization comes in. In other words, how many times did you go to the ER? How many times did you use the inpatient facilities? How many office visits did you have? That kind of information flows in as well. It adjusts that risk number either higher or lower based on that utilization.
The purpose being that impact pro is for predicting what might happen.
Correct.
Versus this is, okay.
Correct,
Okay.
and it's a very good predictor, and that's why actuaries use it. So for example, let's say you got a really healthy person, right? I'm not going to use me as an example, I'll use my son as an example. A really healthy person hardly ever goes to the doctors, right? And now you have another really healthy person, but they go to the doctor all the time because they're hypochondriacs, right? Guess what? In this application, they're both going to look like really healthy. They're going to have exactly the same score, right, in here. But in Impact Pro, the guy that's using all of these resources looks really bad because he's gone to the ER 3 times because he had this back pain. He thought he was going to die. He had chest, it's all hypochondriac, but he's using resources. None of those things actually count towards an episode of care because they were all discounted.
So the claims are only used comorbidity, that is the conversation we had earlier, that you were asking.
Not
Without
just,
taking into account-
okay, go ahead.
Without
Kid.
taking into account the utilization. When you're looking at
Correct.
the retrospective
Correct.
part.
Right, utilization doesn't play into the overall health risk in this application, whereas an iPro plays into it big time.
So when you say claims, you're really talking about existence of comorbidities.
Yes, yeah. We're looking at diagnosis codes here, mainly, whereas in the other one, we're looking at both diagnosis codes as well as utilization, how often do you go to the hospital. Okay, we go to the next one. Okay, so here's the retrospective risk categories, and we said we had 26 of them. Well, there they are, and that's kind of the percentiles that the number of folks fit into within the overall application. So when you go to look at that, now we've already done this, so we'll just flip by that. Service classifications are a good one. CPT codes, HCPCS codes, revenue codes, any homegrown values require mapping into the national ones. So we do that. In this case here, standard CMS codes for place of service are used. Most of you guys are submitting that anyway, but if there is some that aren't standard, then we have to pop it in there. What we are seeing in this area here, especially in the home area, some places are trying to tease out hospice versus non-hospice. So we're trying to actually work on the application to actually be able to tease that out a little bit more effectively. Yep, next. And here's the hierarchy for types of service. In the application, there's actually 5 levels of types of service in 2.1. We have always a type of service code, and then at the very highest level, we actually combine these, and then they get dropped into something more detailed, and then more detailed, and then the most detailed. After the last type of service, you're going to get to the CPT code. Categories, this is profile service categories. Remember I said certain physicians aren't as responsible for certain activities as other physicians are? These are the categories we use, and that's how we assign responsibility. So for example, if I'm a primary care physician, I am definitely highly responsible for my primary care. I'm also highly responsible for the specialty care. I'm not quite as responsible for hospital and ER, and I'm somewhat responsible for lab, radiology, and pharmacy. So we apply, for each one of these here, we apply a percentage that has to add up to 100%. So if I were looking at this from primary care, I would probably, and you can see this in the configuration workbook, the exact numbers that we apply here, but in primary care, it's probably something like 20% for primary care services, because I am the primary care doc. Specialty care, probably another 20%, because I do the referring out to the specialties. Hospital, I'm probably at 5% as a primary care, because I don't put anybody in the hospital. I'm probably at 5% for the ER, and then the remaining percentages get divvied up there. But the weight is really on primary and specialty, right? If I'm a specialist, hold on a second. If I'm a specialist, right, the primary care is like maybe 2%, because I don't refer back. If I'm a specialty care, that's a high weight. Hospitals, a high weight. ER, again, kind of a low weight. I might give more to a certain specialty that uses radiology a lot, like orthopods. I might make a higher weight in there. And I might give more to somebody like endocrinology that has pharmacy that use it there. So the weights all vary. And then what we do, in order to risk adjust, we take each of those activities and hit it by that percentage for that particular physician category. Yes, ma'am?
What happens with preventable ER visits or hospitalizations, like?
Still in the ER.
But do you give more, do you make the primary care provider responsible for a few of those, like UTIs and things up in the ER or a hospital?
Yep.
Primary care doc should have taken care of it.
Correct. Is the primary care doc responsible for the member actually showing up at the ER? He has no, members, if they have a UTI, they're likely just to go rather than contact their primary care doc, unfortunately. So we don't give a weight based on the type of thing that happened in the ER. If it's an ER visit, it's an ER visit. But we do have, as we talked about earlier, these preventable ER visits, and basically all that happens there has nothing to do with the weights, nothing to do with how the risk is calculated, but everything to do with informing the physician that these number of members hit the ER for these conditions that should have been avoidable by you.
The only place it gets a little sticky is not ER, but walk-in. When you have FPs who work walk-ins, we've seen data a little bit harder to decipher. Like you'll see what is going on with this care, and you'll go and say, "Oh, that's one of our walk-in docs. They don't see patients on a regular basis."
Oh, Okay.
Similar, but they're getting grouped into a primary care group because
Mhm.
they're in a
Yep.
P by degree. So that's where when you do the dive down, you can figure that
Yep.
out. But
And the affiliation should cover some of that, right? 'Cause
some of it,
yeah.
But not all.
Okay. That's fair. Next. So some key methodologies. Now we're going to kind of dive a little deeper into ETGs, ERGs, and EBM Connect. So let's go to the next one. Keep going. Okay, so basic classification methodology. I think everybody, well, let me ask the question. Does everybody understand ETGs, ERGs, and EBM? If you do, we'll skip a piece of it. No? Okay, so let's kind of cover this lightly, and then we can talk about it more deeply if there's questions that come up. What do? We take all these claims coming in, and we run it through this grouper engine called episode treatment groups. The episode treatment group engine has 80% market share. There are other engines that group too, right? There are DXCGs, they do grouping. So is there a good grouper? Is there a bad grouper? No, they all work about the same way. They take claims and they stick it into meaningful episodes of care. So for example, you go to your doctor's office and you have diabetes, and he marks you off as having diabetes, but he also gets the lab work done on you, and he gives you some pharmacy. That's all related to diabetes. All of those things come together to form that one episode, and that doctor's responsible for the whole thing. They're clinically homogeneous. In other words, it doesn't matter where I'm having this stuff done. If the clinical condition is diabetes, it's going to get lumped to that episode. So I saw the doc in his office. I got a couple things done, and you're going to see a slide in this in a second. Then I went to the ER because my blood sugar went too low. Well, guess what? That's going to get lumped into this episode. From the ER, I got admitted inpatient because I was really bad. Oh, that's going to get lumped into the episode. After I get discharged, I go back and see my doc who prescribes a couple more meds. That gets lumped into the episode. So no matter where it happens, no matter how long it takes, it's clinically homogeneous for diabetes. Now, if after I got discharged, I broke my leg and I went to see my doctor in the meantime for the broken leg, that would be a separate episode that would not be part of the diabetes episode, but would form a broken leg episode all by itself. And then everything that was attributed to broken leg, going to see the orthopod, getting it set, blah, 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 that would be another specific episode. They're severity adjusted, and we've already kind of seen how severity adjustment works. Keep going.
How do you group it if somebody's got diabetes, CHF, so they come in with multiple, you rarely have someone with just diabetes.
Correct.
So when you are billing,
Yep.
and you put your primary diagnosis as diabetes,
Yep.
however they have all these other conditions.
Yep.
How do you label that episode? Do you
How do we
label
tease it out?
Do you label it how I put the primary diagnosis as, or do you guys?
We look at all three diagnosis codes, right, in 1.3, and we have 5, yeah, in 2.0, yeah, and we look at all of them. So for example, if you have diabetes and you have high cholesterol, we know enough that there is a difference there, and we can actually create two distinct episodes of care, and we'll take the cholesterol drugs and apply it to the cholesterol piece of it. We'll take the diabetes drugs and apply it to that. If we can't determine that, then we're going to stick it where it makes the most sense, or call it an orphan. And we can call things orphans as well.
So one thing that has come up pretty frequently, and while we've been talking about primary care public reporting coming up next year, is where does the office visit go? If I'm seeing the patient and I'm coding diabetes and hyperlipidemia
Yep.
and hypertension all in the same office visit.
Mm-hmm.
So where does that office visit go if you have 3 episodes?
Well, you're not going to create 3 separate episodes for that single individual doctor, simply because that's going to be duplicative in terms of the dollars going into the peer groupings. So what's going to happen is the primary diagnosis is going to come in first, and the secondary and tertiary diagnoses are going to add to the comorbid conditions that that particular patient has. Okay, keep going. I want to get to the, keep going. Keep going. Keep going. I don't know where to, this is it. This is the slide. So this is the slide that we wanted to talk about in terms of how do you form an episode of care from claims, right? So in this particular case here, what we've got is we've got an office visit that happened August 22nd. Now, the key thing to office visits, or the key thing to any one of these clusters that are developing as we come across, is you've seen a face-to-face visit with a physician or a provider. So in each one of these clusters, as they're building across, you're going to see that they've seen a physician. They've seen a physician. This was a hospital, so that's a facility. They've seen a surgeon in this case here. In this case here, they saw a physician over here. So what we do is we look at things that happen nearly at the same time. So we saw a physician, had a physician office visit, they had some lab work done. Couple days later, they went back and they saw their doc, and it's like, oh my God, I'm feeling absolutely horrible. Doc says, okay, go see the surgeon. Surgeon takes you to the hospital, a bunch of stuff happens in the hospital, and then kind of nothing happens a little bit because you're in the hospital. You get out of the hospital September 10th, you get an RX from your doc, October 15th, you refill that particular RX. If you look at that from soup to nuts, and that's all the same clinical condition, that forms an episode. So all of the claims from the lab, from the pharmacy, from the hospital, all those claims form that particular episode. Now, who gets attributed that episode? That's the next question. Well, I have two different peer groups here that I can see, right? I've got a peer group that's probably your primary care or some specialty like cardiac, right? And I've also got another peer group here that's the surgery peer group. So that, if that's the same guy as this, then it gets attributed to that particular one. If this is the PCP and this is the surgeon, this can be attributed to both of those because they're separate peer groups. So all of that stuff would get attributed to the surgeon, and all that stuff would get attributed to the actual PCP. We're not duplicating stuff here because they're in different peer groups, right? We're not giving this guy twice the responsibility of cost. We're giving each one a little bit. If this is the same doc right here, then everything goes to that one doc in that one peer group. Can we flip to the next one? Because I got a couple more, I think, that actually, yep. Complete episodes. There are several different kinds of episodes in the system. We have episodes that start and finish within the 27 months of data that you're giving us. If they start and finish in the 27 months, and we have what we call a clean period, so there's nothing that happens within 30 days, 60 days, 90 days after the end of the episode, depending on the clinical condition, that's called a complete episode. So we know when it started, we know when it stopped, the clean period ended. We also have episodes that don't end. They're year-long episodes. They're chronic episodes, diabetes, asthma, those kinds of things that never disappear, they're year-long episodes. So you can have multiple year-long episodes. You can have asthma, you can have diabetes, and then within that, you can have acute conditions. You can go in for sore throat. You can go in for a broken leg. You can go in for appendicitis. And those have clean periods at the end of them. So you can have multiple episodes for a single member in a given year. The clean period is different, and it's different by medical and pharmacy. So for example, if we're looking at a case of sore throat, for example, it may have a clean period of 30 days. So if we see no further claims in 30 days, because typically it's you give a Z-Pak out 7 days later and you never see your doctor again, that is a clean period for us. So that means that episode is closed. But if we continually see activity, so I go in, get strep, get my Z-Pak, 4 or 5 days later I go back, it's still sore, get something else, 5 or 6 days later I go back to a specialist ENT, all of that still adds in. The clean period hasn't hit yet. Each ETG has a separate clean period. If you want to know what the clean periods are, there's a spreadsheet for that. And every ETG has it. It tells you what the clean period is. It tells you if it's chronic or acute. Services for the same condition outside the clean period can create an additional episode for that same condition. So for example, let's say sore throat, and the clean period's 30 days. So I had a sore throat, it really, really, really hurts, and I get some meds, and then I don't see a doc for 3 weeks. Okay? I see the doc the 4th week. Because that 4th week is inside the 30-day clean period, it will not form an additional episode. It just goes to it. Now let's say I see him 5 weeks later, right? Same sore throat. Could form an additional episode there because the clean period has been broken.
Well,
Yes?
could you explain again the chronic disease clean period of say 12 months?
Yes, correct. Yep. How it works is if you're diagnosed with diabetes, it never goes away. Therefore, everything that's diabetic care gets lumped into a single episode called diabetes. So for the entire year, your A1Cs, your drugs that you're taking, your insulin, your doctor's visits that have coding of diabetes on it, all that stuff gets lumped into that one episode. It's for a year.
So is it 1 year from the measurement year, or is it from the date of diagnosis?
We were just talking about that the other day. No, it is for the measurement year. Yeah. Now, you can have partial episodes, right? So, for example, diabetics, if they disenroll, they will have a partial episode. So, let's say, for example, I'm diagnosed in the 4th month of the year. All of a sudden, my full year episode begins, and I've been a member since January. Well, I quit. I'm no longer a member. I'm no longer submitting data in July. Instead of having a 1.0 for that episode, it's a 0.5. So you can have partial episodes. Now, why do we do? Oh, you're looking at why do we do that? There's a great reason for this, right? We do this because if we don't cut it in half, the care that that patient should have gotten but didn't get will go against the doctor that was seeing him. So we want to, put a balance on it, and that's why Sarah and I were talking about, well, why don't we start it from the date of diagnosis? And that's not something we do because essentially we assume that if you got diabetes, you've always got diabetes.
So, well, sorry.
Yep, no, go ahead.
Let's say measurement year is January to December.
Yep.
Somebody gets diagnosed in November.
Mm-hmm.
And they don't have enough activity to show that the A1C
I know.
were calculated. So how would that?
That's going to show up as a full year diabetic episode. Yep.
And it'll show opportunities missed.
It may, but let's say if you're first diagnosed, the odds are it's not going to show opportunities missed because you're going to get your A1C immediately. You're going to probably get some drugs immediately, so it's probably not going to show that. Because here's an example. You're coming from diabetes, right, and you're taking insulin. Well, the first time you walked into the doctor's office and were diagnosed diabetes, that's the first time you got insulin. So the system doesn't know that you may or may not have had insulin before that, so you won't be gigged for not taking your insulin for the months prior to that, but it will be a full year episode still.
What if I change health plans in June and, so
Yep.
you have my history?
Single member ID, no problem.
All right, what if I start as a new member of the system in June, you have no history on me?
Yep.
Then I don't have enough time for you to.
So we-
determine that I have
yep.
diabetes, even though I may.
Yep,
well,
yep. It'd be a half year episode in that case because you started your enrollment in June.
Then it would be retrospective because,
Well,
you-
whenever we figured out you had diabetes, it would be retrospective to June when you started.
Okay, so you figure it out because I have all sorts of
Yeah.
activity, and then by
Yep.
September you conclude, well, yeah, this
Yep.
person has diabetes, and it starts.
Correct. Yep. And the only reason it started in June was not because we identified diabetes in June, was because the member enrolled in June.
Right.
That's the difference. Subtle, but it's not. Oh, I'm sorry.
I can exclude partial
Claims.
episodes, right? And then I adjust for that, right?
You can, if you wanted to. It's not going to look like a partial episode, though. It's going to look like a full year episode unless the enrollment dropped.
Oh, so if you enroll late, doesn't matter. If you drop only, then you see a partial enrollment or partial?
No. So her example was a half-year episode because the member enrolled in June, right? In your case, the member dropped in June but was a member in January. There's still a half-year episode. Yeah. Oh, I'm sorry. Wait. She had her hand up first. Sorry.
So for the diabetic patient that you said that has a full year episode.
Yep.
If they're seeing primary care but then also go to endocrinology,
Mhm.
they will both be given.
You got it. You got it. As long as they meet the threshold criteria of having a face-to-face visit and they're the only one in that particular peer group, then they will get accountability for that particular episode. So the PCP gets it and the endocrinologist gets it. Now, if there are two endocrinologists involved, then we discriminate and we say, I think yours is set at 30% still? Yeah. So what we say is, in that peer group of endocrinology, does either one of these doctors have 30% or more of the care? If the answer is yes, that's the doctor that gets it.
If it's no,
If that, then they don't get it.
Either one.
Nope. You got to meet a threshold.
but if it's only one endocrinologist, there's no threshold.
Well, because they have 100% by definition.
Okay.
And quite frankly, when I said
I guess
two,
I'm
by
confused.
definition, two means 50-50 or some semblance. So one of them is going to get 30%. But it's when you get to like 3 or 4 people involved, that's when you have to start hitting those threshold limits. But if you only have one involved, it is what it is, right? Because it's 100%. If you have 2 involved, I can't imagine a split that says anything less than 7. Even if it's 80-20, the 80 gets it.
But it.
And it's
there's
cluster
also-
counts, too.
Yeah,
Yeah.
there's also a condition that says the specialty must have X%
Yep.
of the total
Episode.
for the episode.
Yep.
So even if there was one endocrinologist if there's a cardiologist and
Yep.
some other physicians involved in that episode, and the endocrinologist doesn't have 30%
Yep.
of the total,
Yep.
then they won't win the episode either.
Yeah.
But you're not comparing them to the primary care, only to the other specialists. Is that what you're saying?
In the peer definition,
Yep.
yes.
The best way to get the details on that and see what the percentages are is to look at the config workbook for each peer group. I'm pretty sure they're all going to say 30 though, and number of clusters.
Yes,
Yeah.
yes.
Because you get defaults.
Yeah.
Sorry.
So I guess for how an episode's defined, if a member has some chronic condition like hypertension,
Mm-hmm.
and say it's just, we're talking calendar year, so they were diagnosed the year before and then
Mhm.
put on like a beta blocker or
Yep.
something. So now they don't see their PCP until sometime like maybe November again,
Mhm.
but they've been, every month they've filled a script for a beta
Mhm.
blocker. Would it not be a defined episode until, now they went into
It'll be
a
an episode,
PCP?
but it won't be assigned to a PCP or anybody because you don't have a face-to-face visit. The only way, it's gone. But the only way to actually get an episode assigned to a doc is if you have a face-to-face visit. You have to have that.
So they'd have, the whole year would be a hypertension episode, but it wouldn't be assigned until.
I'm a classic example of that. I never go to my doctor and I have hypertension and I take my drugs. So I'm a classic example of that.
So there's an episode for your hypertension,
Yep.
but it's not attributed in provider network assessment.
Right.
Because there's no doc to tie it.
No doc to tie it to. Now, if there was a cardiology visit, for example, in hypertension, that doc in cardiology would probably get that one, only because cardiology and hypertension go together as well. Now, if I used my endocrinologist and you had hypertension set off in the endocrinology one, and I used my endocrinologist all the time as my PCP, it would go there. But attribution of an episode is different than creation of an episode. An episode is created at the individual's level. The attribution happens when you look at who saw the patient. Two different things. Okay, let's flip. So here's an example of building episodes within a clean period, and the medical clean period is 30, where the pharmacy clean period is 45 days before and 120 days post. This kind of goes to your question of what if I got drugs before and what if I got drugs after, right? So in this case here, you've got episode 1, you've got episode 2 over there, you've got 3 clusters of activity. You've got an RX, a medical, and here you've got some more clusters here, and you can see the clean period ended here. The clean period for pharmacy ended out there, so that makes a complete episode over here. But over there, the complete episode starts there and moves forward. So you can have episodes within episodes. Keep going, paint the screen, I guess. Oops. So in this particular case here, we have episodes that are unknown starts and unknown finishes. So for example, you start January, you give us a bunch of data. It starts January 1st, right? It's very possible that some stuff happened out here before January 1st. We don't know that. But the rest of the episode gets created, but it gets called an incomplete episode. So you can have incomplete on this side. On the opposite side, we can start an episode and the clean period doesn't finish by the end of the run out. So we have an incomplete episode on that side. So there's really 2 kinds of episodes. Complete and incomplete is the big picture. Within complete episodes, there's a variety of types of complete episodes, right? There can be chronic episodes, which last for an entire year, or partial year episodes. Within incomplete episodes, you can have incomplete, unknown start, incomplete, unknown finish, incomplete, unknown start and finish, and those don't get used in provider network assessment. Any incomplete episode will not get used. Now, episodes that are complete may get used in provider network assessment if A, they're attributed to a doc, and B, they're not a low outlier. Low outlier episodes based on cost are just thrown right out of the equation. High outliers are truncated by ETG at a certain dollar value. So you're keeping high outliers truncated and you're keeping all complete episodes for PNA. Okay. Now, this is kind of a breakdown, and we're going to see this afternoon. In the online cubes, you can start out with the highest possible level, which is MPC. Then we can break it down into the families of things going on. In this case here, atrial fibrillation and flutter, ischemic heart disease, and there's a whole bunch more after that. Within that, we can break it down to the ETG level, and within that, we break it down to the severity level. And you can see here, we've only got 3 severity levels for the first one, atrial fibrillation, but we've got 4 severity levels for ischemic heart disease. Not every ETG is exactly the same. And here's just an example of where we're drilling down a little deeper into this in ischemic heart disease, and you can actually see here where we have with and without treatment levels. So you're either getting treatment or you're not getting treatment. Let's see. We talked about this, we talked about that, yep. Oh, I already showed that one. We talked about outliers. Which one's this? Oh, these are the chronics. Okay, we talked about these. Oh, well, just stop there because this shows something. Sorry. So here you can see how you can have a half or a quarter of a chronic episode based on enrollment periods. That's all that's saying. And here's where we start looking at how are we risk adjusting the ETGs. And basically we're showing a couple different graphs here. The top graph here is essentially showing us, one set, and these are all the individuals in that particular one. And the bottom one is showing, the peer group, and here's all the mix. And you can see that, okay, it's about the same, and that works out well. But if it's different, what we try to do is we try to level those out during the risk adjustment. Raj?
I'm sorry, I lost what those sets are.
Oh, these are, consider these like number of patients in each one. So there's 906 patients here, there's 1,900 patients here, and we're scanning.
How do you form those 10 sets? Are those the 10 levels of severity?
What is the x-axis?
Yeah.
The x-axis is the number of members in each of the buckets, 1 through 10.
What are the
How are you
buckets?
forming the buckets?
I'm sorry?
What buckets are these?
Oh, go next slide.
Oh, sorry.
That's, oh, well, how about, oh, wait a minute. There we go. We take those 10 buckets and we collapse them into 4 buckets. So we start out at very fine, and then we collapse them back down into 4. So this,
Deciles.
deciles, yeah.
Oh,
Of
okay.
what measure?
Yeah.
Got it.
Sorry.
Sorry, that's deciles.
Yep. And
you're converting deciles to 4.
yeah, in the application itself, we also have the ability to do ranking, and we do it at the decile level. So we can actually rank physicians. Nobody uses it, to be quite honest, because everybody uses the risk adjustment and the index built in. I don't know, do you guys use those? No, okay. I didn't think anybody used them, to be quite honest. There's a couple things in the app, that and those graphs that really nobody utilizes. But we're trying to just risk adjust the docs so that they're on a level playing field. And when you get to deciles, unfortunately, the numbers start to get thin. Thank you. Yep, exactly.
So are these quartiles, or is there a different algorithm?
No, there's a different algorithm for these. Absolutely. That's just the same kind of thing, actual over expected, ETG adjustment. Let's see. Okay, so I guess in here, the only thing that I really wanted to kind of home in on is when we're looking at this and when we're looking at ETGs and assessing them, we can assess a provider performance across specific ETGs. Just pick one, diabetes, and we can look at the provider performance. Or we can look at everything that provider's done, diabetes, asthma, COPD, et cetera, and assess them directly. Now, the difference here is the numbers, right? Diabetes is fairly easy because you've got large numbers to work with. But there are some ETGs where there's only a couple things happening. You only see a couple patients that have this particular condition. So what we try to do is we try to collapse them into like categories. Remember we saw the MPCs going into the family, going into the ETGs? Well, as you drill your way down, it gets finer and finer. When you get to the severity level, with and without treatment, you may have 3 people in those categories. You can't compare. So what we do is we bring it back to the point where we can actually do comparisons. Most physician groups will accept, easily accept, ETG with severity level. That's a given, right? They'll accept ETG without the severity level because we're adjusting for it. That's a given. Now we move up one to the family. It's getting a little dicier there, but most physicians are still accepting family. You move up to the next level, forget it. They're never going to accept that. So you want to keep it at a point where you have the numbers in at least the family to the ETG and going forward. And that's back to the app. I guess we're set now. What time is it? And I did see lunch arrive. Why don't we do lunch? Any questions? And what we're going to do this afternoon is we're going to jump into the online analysis cubes. You guys get to go into your application, which is even more fun.